It's forcing us to look at the concept of how we eat and how food fits into just every aspect. It's weaved into every aspect of our life because food is the constant, right? We can choose not to exercise. We can choose not to manage stress. You can't choose not to eat.
Hey everybody, this is Lori Scholweiss.
And I'm Jen Giamo.
And welcome to another episode of Everybody Talks, the podcast where we explore the wide world of wellness. Sometimes we talk to experts, sometimes we talk to each other, but we're always talking to you.
Every week we discuss topics from nutrition and exercise to mindfulness and self-care. And today we are talking all about metabolic profiles and your liver.
Wow, you're not going to want to miss this one, so let's get started.
Okay, she is a registered dietitian, a best-selling author, presenter, president and CEO of KAK Nutrition Consulting, a dietitian with the Department of Wellness and Preventative Medicine at the Cleveland Clinic, very impressive, and a senior fellow with Meadows Behavioral Healthcare. She's appeared on the Today Show, NBC Nightly News, Fox News, among many others, and she's also contributed to publications such as the New York Times, the Wall Street Journal, and Time Magazine.
Together with Dr. Ibrahim Hanouneh, she has co-authored the book Skinny Liver, a proven program to prevent and reverse the new silent epidemic, liver disease, and their latest book, Regenerative Health, Discover Your Metabolic Type and Renew Your Liver for Life. Please welcome Kristin Kirkpatrick to Everybody Talks. Hi, Kristin. Welcome.
Hi. Thanks so much for having me, ladies. I'm just so excited to be on your show. It's a great one, and I'm happy to be one of your guests.
Oh, thank you so much.
We're excited. We're excited. This is definitely a topic that we haven't
haven't talked about. And it's really interesting.
It's so interesting. And I was reading through the book and, we've talked a lot about metabolism as it relates to weight management here. And I have a nutrition background.
Why don't you tell us a little more about yourself, anything we might have, and maybe how you met Dr. Ibrahim. I'm going to just use his first name.
Thank you. Sorry.
Sure.
So I've been a dietitian for over 20 years. My entire career has been spent at Cleveland Clinic in integrative medicine. When I was doing our first book, and let me just back up for a moment. It's really interesting. It's interesting writing a book in general, right? Just like the concept of trying to come up with the subject and things like that. And I think when I was first trying to figure out what should my first book be, I was thinking it could be just weight loss, or it could be eat these things and not those things, right? And I was really missing the mark. And really all I needed to do is look at my patient base to get the answer. And so what was happening was I had these patients come in and say, I saw my doctor, I have insulin resistance, or I have central obesity. He or she says, I probably have fatty liver. There's no drug to solve it. Go see a dietitian. So here's where I'm at, right? So there was no guide. There was really nothing that was special to really, what do you do when you have this type of condition? So this really prompted me to say, okay, let's do a book about this. And then in addition to that, I needed the medical side of it. So that's where Dr. Hanouneh came in. It was really about, okay, let's get someone who is a world-renowned hepatologist who sees these patients day in and day out, not talking about diet. He's doing the medical side. I'm doing the dietary side. Let's come together. So I was able to shadow him at Cleveland Clinic for a long time to see that medical side. That's really how our partnership really came to be. But it's so interesting that I had all these patients that were like, well, my doctor says I probably have this. I don't know what it is. I didn't know I had this, but you're a dietitian. You're supposed to be the answer. So this is what's really prompted us to kind of focus on this. I mean, 1 in 4 individuals has fatty liver, and most likely there's more that have not been diagnosed. So it's really prevalent, and we just need to keep having the conversation.
Yeah, I had no idea how prevalent it was. And now that you're saying that, that's really kind of shocking.
Also, I had only heard the phrase fatty liver associated with alcoholism and an over drinker. That's where I had heard that before. And so you don't think of yourself. I mean, although I have to admit to carrying weight around my middle, as a lot of people do, it didn't occur to me that could be something that would happen, that I would have, which sounds like maybe I do, but I don't
Well,
know.
and that's a really interesting perspective as well, because, when I was working with Dr. Hanouneh, one of the things that I noticed when he would meet with patients and I got to shadow him was a lot of people would say, oh, that's impossible. I don't have this. I'm not a drinker. So there was almost
Yeah.
this stigma of, well, I couldn't possibly have this or talk about it because I don't drink enough to be one of
Right.
those people, right?
Right.
So there was this stigma, but it has nothing to do with drinking. In fact, this is really interesting. And this came at the heels of writing the book. The major liver associations have now really renamed it from non-alcoholic fatty liver disease to metabolic associated dysfunction liver disease, fatty liver disease. And thank God they did, because really using that terminology is much more inclusive of the fact that this is metabolically related. This is related to our metabolic numbers. This is related to dysfunction in some place in our metabolic life. Has nothing to do with drinking. Now, if you have fatty liver of any kind, limiting drinking is obviously suggested. And if you are at the latter stage of cirrhosis, then zero drinking. But really, the formation of it doesn't have to do with alcohol, which, is very interesting, because you're not unique here. Most people are like,
Yeah.
oh, my liver is great because I don't drink that much alcohol, or gosh, I hope my liver doesn't have fat because I drink so much.
Right.
Yeah.
So Kristin, how is it diagnosed? How are people finding out that they have this?
So typically what happens is that people will come in for something else. Rarely will people come in and say, hey, I think I have fatty liver. Can you run my numbers, things like that. So people will come in for their primary care physician, and their physician will say, you know what, your waist size is a little too high. So let's say if you're a female, that's going to be over 35 inches. Or we could say, hey, your hemoglobin A1C, which is a 3-month marker of blood sugar management, that tends to be, you're in the pre-diabetic range. So, there's a few things going on. Or you are looking at high glucose, or your liver enzymes could be up, right? But really, when you look at some of these things, when we look at someone who's insulin resistant, or we look at someone who has type 2 diabetes, the chances of them having fatty liver disease are probably about 75% or greater.
Wow.
So if you have dysfunction within blood sugar management, most likely you have an abnormal amount of fat within the liver as well. So typically it is a diagnosis that looks at what are all the factors that are leading to this. And then we can assume you probably have this. Now, some physicians will go a little bit further. I know in Dr. Hanouneh's practice, a lot of times he will do ultrasound to just kind of see, can we see excess fat in the liver? And so that's a little bit more diagnostic. A biopsy would be a little bit more on the extreme side. But usually it's let's look at your general health, and then let's look at what are the chances that you most likely have a condition like this.
Okay.
Wow.
So would it be safe to assume people that are diabetic, insulin resistant, or, have trouble managing their glucose, this would be something that is probably happening for them?
Yeah, this could be a real probability. And especially if it goes alongside other metabolic abnormalities. So if let's say, for example, your waist size is too high, just like we were talking about.
Yeah.
Of course, if your liver enzymes are too high, even looking at something like your lipid panel. So things like that. I mean, really the criteria of metabolic syndrome in general is, high lipids, low HDL, high blood pressure, your blood glucose is abnormal, waist size. So really, if you're fitting the factors for metabolic dysfunction from that definition, then most likely, you can probably assume you probably have a little bit too much fat in the liver as well, because the liver's not able to keep up with the dysfunction, especially of the blood sugar management.
Okay.
Is the liver producing its own fat, like separate from just...
So what happens is you have storage of fat that occurs. So the liver is involved in like so many metabolic, I always call it like the magical metabolics of our body, right? The liver is involved in so much of it. And we don't think about that, right? We think about our brain, we think about our hearts, we think about our pancreas when we're thinking about blood sugar management. But the liver is really, like we said this in our first book, It's kind of like the guy behind the curtain in Wizard of Oz,
Yeah,
pulling all the strings
sure.
and telling everyone else what they need to do. So when we have dysfunction in blood sugar management, when we have something like insulin resistance, the liver is responsible for controlling blood sugar levels or keeping a state of homeostasis within our blood sugar as well. So what happens is when our blood sugar is mismanaged, so we either have insulin resistance, type 2 diabetes, the liver will sometimes be more prone to be storing that excess fuel as fat. So, and it occurs right there in the liver. So 10% of your liver having fat is normal. We all have some fat in our liver. But once we go over that because of this mismanagement, that's when the liver gets a little bit less on how it can function, right? Like imagine a cup, and the more that cup is filled with water, the less space you have for that cup to really do anything else. The liver is really similar to that. So the more fat that accumulates within the liver, the less space or healthy cells are available to do its job in every other capacity within the body.
Got it.
Jeez.
Just explain, just for our listeners too, talking about fat around the middle and fat in different areas of your body, just the difference between visceral fat and subcutaneous fat, just for people to kind of understand that.
Yeah, visceral fat is the one that's kind of near your organs, near everything like that's important. Let's just say that. And so that's really the kind of fat that you really want to really reduce because it's deep within the belly, right? Whereas the other types of fat are really not as deep within the belly. They're more like away from organs. So generally what I tell my patients is that I want you to lose fat. I don't want you to be worried about what kind of fat it is. Doing some of these actions will help with reducing waist size and will help reduce all kinds of fats, right? Brown fat tends to be a little bit more beneficial, but we don't have that much of it, unfortunately, right? But I think so that's the most important thing to think about. The visceral fat is really when we think about belly fats. The bulk of my patients are females that are peri and postmenopausal. Sure. That's like my sweet spot of who I see. And that is me as a woman. So I'm very highly motivated to see these types of patients. Most of those patients are dealing aggressively with belly fat. And, even just looking at the fluctuations of estrogen and how that increases belly fat. So like that, just the belly fat in general, I think is really what the high level is that I want people to focus on in my practice.
Yeah, we definitely talk a lot about that.
Yeah,
here
we do here.
Yeah.
I
actually had just started hormone replacement bioidenticals about 3 months ago. So. And the difference that it's made in that belly fat, the bloating that I was having, it's like unbelievable.
Yeah.
It's so interesting to me.
Yeah. And a lot, it's and to that point, I will say, one of the most challenging thing is when I work with patients who are not able to, for whatever contraindication, they can't take hormone replacement therapy. Yeah. So they're really like in this desperate spot, and then, of course, like we could talk about this, right, for hours. Then all of the other health risks that occurs once we get into peri and postmenopause due to that lack of estrogen. I was just seeing a study, I think it was last week, just looking at the incidence of hot flashes and the risk of dementia. So it's really interesting to look at kind of this combination of, estrogen, and when it lowers in the female body, just everything that goes wrong, right?
I was talking, I'm postmenopausal. And I didn't do hormone replacement therapy. And I wish I had known the things that I've learned on this podcast, quite frankly, 10 years ago, 15 years ago, 20 years ago, because I feel like I would have benefited so much. But I guess I've been told it's not too late for me to do it. But, I'm not as motivated because I'm past all the, most of the symptoms. Yeah.
But that's, I think, to your point, Kristin, is like there are so many other benefits to having that estrogen as you age, protecting your heart, protecting your brain, all those things. Yeah. So forget about the symptoms. You might not have the symptoms anymore, but you could be doing other beneficial things. Yeah.
Yeah.
That's so. I know. I feel like we could talk about that forever. And even even the stuff that you were saying about the different types of fat, and
She's very into
I'm
that.
so into that. Well, it's,
you can tell who has the science background and who is the dum-dum of this pair.
Well, no, when you mentioned brown fat, that is something, this is so funny. When I was getting my master's in nutrition, and I remember, because it was only really discovered like in the 50s or 60s that this was like a metabolically active fat. And I remember right. And my professor talking about it, and I was like, well, what is that? I want brown fat. How do I get it? And I remember him saying, he's like, well, it's mostly between your shoulder blades and babies have it. But now they're saying it's like, concentrated more like in your neck and collarbone and shoulder, whatever, all that stuff. So anyway, I could do a deep dive into white fat and brown fat and how you get, but I won't go there. I'll save you.
You save me from that?
I'll save you. But just going back, so I want to talk about these metabolic profiles that you talk about in the book. The preventer, the fine tuner, the recalibrator, and the regenerator. I don't know what any of these are. So dive right in, explain.
So really what motivated us to come up with the metabolic profiles is we spent over a year really looking at the data of how inefficient BMI was. And yet we were still using it in our practices at large medical institutions, right? We would say, oh, here's your BMI. And so we just want to bring that BMI down, right? But what I typically say to my patients is the BMI will tell you the same thing that the scale will tell you. And that is, what's your stuff? What do you got in you? But it won't tell you any specifics. It will give you just a general assessment. When someone comes to see me at Cleveland Clinic, what I would have typically done is put them on this really detailed in-body machine. And we would be able to see what is the amount of fat, muscle, and water within each arm, each leg, and then your trunk.
Wow.
And that then provides a better picture. So as we looked at really what was going on in fatty liver, the metabolic dysfunction, the waist circumference, we decided to put those two together to really stage someone for how aggressive or less aggressive they need to be towards a more liver-friendly plan, right? Okay. Yeah. So the preventer is going to be healthy and lean. It's going to be your normal individual that might have some sort of genetic risk factor. For example, one of the things we go into in the book is that if your mother had fatty liver or she had poor diet and then birthed you, you are much more prone to get that later on in life. So that could be someplace where your waist size is normal, your metabolic health is normal, but you've got this genetic risk. So maybe you should look at really kind of taking a little bit more attention here. The fine tuner is healthy and non-lean. So that means your metabolic numbers are pretty good. Your cholesterol, hemoglobin A1C, looking great. But maybe if you're a female, your waist is 40 or it's 38. So it's above what the normal is. So now we have to start looking at, well, your numbers aren't there yet, but your waist circumference, if we don't get this under control, your numbers could worsen. It could worsen fatty liver as well. The recalibrator is unhealthy and lean. So that means your metabolic numbers are not good. Your cholesterol could be high, hemoglobin A1C could be high, but you are lean in your midsection. And you could even be a skinny fat. So if we go back to this concept of weight and different types of weight, maybe you look great in a pair of jeans, but everything there is really just fat. It's just underneath not fat.
Yeah.
Right?
I know. Yeah.
And then the regenerator is unhealthy and non-lean. So you both have a high waist circumference, but you also have your metabolic profile is also abnormal. So your HDL may be low, your blood glucose may be high, any of those numbers. So we really just kind of wanted to put people in a place where their body was telling them, here I am, right? So, if we look at someone who is, for example, non-lean and unhealthy, right? So looking at this regenerator, this is someone who we would say in the book, you could probably benefit from a more moderate to low carb approach and some other things that, we think are going to be beneficial for you. Whereas if you're at the top level and you are the preventer, healthy and lean, then a Mediterranean approach would be just fine. And you probably don't need to modify the carbs, but just a Mediterranean approach. So we really looked at it as what is impacting insulin and blood sugar, since this has such a bearing on overall liver health. And then where's your stage to determine where you should be in that process.
Okay, sure. That's so interesting. So the in-body machine gives you all those biometrics to
Right.
tell you your muscle. Is it similar to a DEXA scan, or how are they
It
different?
is. It's similar. It's similar to a DEXA scan. In our practice, we would run it every 12 weeks.
Okay.
Wow.
Patients would want it run much more frequently.
More.
Yeah, of course.
Yeah, I bet they do.
Yep.
I already want to get in that. I already want to do that.
Well, especially if they're motivated, right? Like if you
Yeah.
that first appointment, you go home, you start hitting the weights, you start really doing well, and then you come back in 3 weeks and you're like, hey, let's get back on the machine. And I'm like, no, we're going to go back on the machine in 12 weeks. It's like,
Yeah.
so in a lot of ways,
Totally.
we like that verification, and that's very normal.
Totally.
Better approach than the scale. And as
Sure.
again, as females, I oftentimes see my patients being very obsessive about some number that they feel will bring them happiness. And that's an interesting perspective, right? When you think about the skinny fat, because I have some patients who are like, they don't have an ounce of muscle on them, but they're like, oh, but the scale is all that matters.
Yeah.
So, and I don't want to tell them the spoiler alert that once they get older and we go back to estrogen, that's going to bite them.
That's
Right.
Yeah.
It's going to come back to really not be in their advantage, but we're not thinking that way when we're not in that state.
Right.
Sure. Yeah, I think, that's also an interesting point, thinking about people who are younger, in their 20s, maybe even early 30s that haven't gotten to this perimenopause stage yet, and they're not lifting weights, they're not doing the strength training. I feel like, and I don't know this to be fact, but I would assume that when they get into perimenopause, that weight gain is going to come on so much quicker than it would for somebody who has been sort of doing those preventative things all along, right? I mean, either way, you're slowing down, you're losing estrogen, but I think for the people that don't have already that muscle mass to combat it a little bit.
Yeah.
It's really what we're seeing in some of the data for people that are on a GLP-1 agonist drug. They get off the drug, they lower the dose, the weight comes back very rapidly.
Yeah.
If they didn't focus on trying to maintain muscle mass during the process of losing weight on
that's the way of the world now, though, isn't it?
And their protein intake and making sure that they're eating enough
Yeah.
protein.
Yeah.
Talk to us about that for a second. I wasn't going to ask you this, but now that you brought up the GLP-1, what do you...
I'm the dum-dum, remember?
Semaglutide.
Yes, okay.
Ozempic and...
Yeah, that's what I thought, but I just wanted to clarify.
Yeah, no, I'm just curious, in your opinion, do you think that people, metabolic syndrome, people who are obese, do those drugs help them to kind of fend off liver disease and all these other, metabolic conditions that they would have? And once they're off of it, or could they never get off of it, what does that look like?
Right.
Yeah. So I think the last thing you said was the most relevant. The question right now that we're seeing in the data is, when you get off of these drugs, are you on lifelong?
Yeah.
Most likely you probably are.
Wow.
Because when you look at the mechanism of it, we have a delayed gastric emptying. We have increased satiety or fullness. The patients that I have that are on these drugs, it's fascinating. It's just fascinating how well they work. But these patients will say, gosh, I have to remind myself to eat.
Yeah,
so we work on really this concept of getting the most bang for your nutritional buck. If you're not eating that much, then when you do eat, it can't be a handful of pretzels.
Yeah.
Right? It's got to be something that's going to give you nutrient density. Protein is a key issue. Things like that. So I think, so that's kind of like bucket number one. Bucket number two is if you have someone who is insulin resistant, obese or morbidly obese, or type 2 diabetic, I think these drugs are a game changer.
Yeah.
They really are, right? They're helping people not only to kind of reduce cravings, reduce intake. There's 350, if you go to clinicaltrials.gov, there's over 350 clinical trials currently being done just on GLP-1 agonist drugs.
Wow.
And some of the trials that they're assessing right now to look at are not just weight, but could this help with addictive type of disorders? Could this help with alcoholism?
What you just said about losing 10 pounds and going off is what I struggle with daily, because I'm probably 25 to 50 pounds overweight, I would say. I don't know. She might disagree or agree. But I work with people who are on some of these drugs. I'm watching them lose weight in a way that I want to lose weight in a healthy way. I struggle with it myself. I'm like Oprah. Oprah was like, no, I don't need that. And then all of a sudden she's like, oh, I'll do that. And because you think like, oh my God, it's just like the easy way out, but it's not really. It's kind of like golden handcuffs, I feel like, when you go on for just like if you're not morbidly obese, which I don't think that I am, I think we could agree. But it's so tempting. It's so tempting, especially in the world now and in like the business that I'm in. The easy fix, if you have something for an easy fix, why wouldn't you want to do that thing,
Right. And I think I think that's a misconception too, that it's an easy way out, because it's the easy way out if you think about it like, I'm just going to take the drug, not do anything else, and then I'm going to be in that scenario where I gain the weight. But one of the things we've been saying to patients that are on the drug and also interested in some of our plans is really being on our dietary plans while you're on the drug can help you with reducing that risk of weight gain. So it can't just be, I'm going to pop a pill and that's going to be the end of it. It also has to be, I'm going to also watch out how efficient my sleep is, how good quality my sleep is. I'm going to manage stress. I'm going to be physically active, especially with weight training, especially what we just talked about with muscle versus fat.
Right.
And I'm going to have a diet that's nutrient dense. Those all reduce the risk that if you lose the weight and you say, I no longer want to be on this drug, then hopefully you will gain back less. You're going to gain back some, but I think Dr. Hanouneh would agree that you're going to gain back some. It's almost a guarantee. But maybe you gain back less if you're doing a lifestyle change in addition to it's not a pill, it's a shot. So I shouldn't have said popping the pill, but you guys all.
No, we know. I know
Yeah,
it's a shot. Yeah, I think everybody in the world knows it.
But so two things on that. So one, I know we're getting a little like off track, but I'm so curious about this and to get both of your opinions on it. Because I have clients too that ask me about it all the time. And I do think it's super beneficial for morbidly obese and reducing all those other risk factors of heart disease and diabetes and all of that. And I think that's great. But to your point, you're saying that when they are taking these drugs, they're feeling full quicker. They're not wanting to eat, they don't have the appetite. So how are they getting those nutrients in if they're not even really able to have a meal that's satisfying, that includes everything that they need? That's my first question. You can answer that.
Well, I think, it boils down to that concept of getting the most bang for your nutritional buck, right? They have to change the mind shift where if they're going to have a snack or they're going to have a meal. And sometimes they have to schedule it in. Some of my patients have said, I actually need to schedule it in. I've actually set an alarm to remind myself that, hey, it's lunchtime or it's dinner time.
Right.
So I think doing that, reducing alcohol is going to be key as well. Like taking away any concept of empty calories. Yeah. So when you think about what's going to be beneficial, healthy fats, looking at fruits and vegetables, whole grains, lean sources of protein, right? All of those rules still apply. You just have to remember that you have to get to the process where you're actually nourishing your body, right? So there's a difference between I'm on this GLP-1 agonist drug and I don't feel any hunger. You still need to nourish the body. And you can only nourish the body so much through supplemental means. Right. Yeah. So a lot of this has to come from food. So you just have to kind of look at it from that perspective. I need to eat within so many hours of waking and I should be eating this many hours. And then I need to eliminate some of those other things. I have a friend of mine who's on one of these drugs. And every time I'm with her, she is like, she's eating candy and have a glass of wine.
I have a friend like that as well. I have a friend like that as well.
No, have an apple, have peanut butter.
Right.
But aren't these things, what's funny is everything you're saying is what everybody should be doing anyway, right?
Right. But like my question is, so do you think that these people are still able to get enough nutrition in given the fact that they're getting full so quickly?
It depends on the individual. That's what I would say. Some people are better than others in being able to achieve that. Some people do have to go on some more supplemental means.
Yeah. Okay.
But it's really kind of like a catch-22. So if we think about overweight and obesity, that is a state of malnutrition. So obesity is a state of malnutrition. So the question is it better to have overnutrition or undernutrition?
Wow.
That's really the question, right? And I would always gear towards undernutrition based on what we know of the risk factors. And even some of the longevity studies on calorie restriction.
Yeah.
So
Yeah,
I just think that is the way to go. But what I think we're not doing is we will get the drug somehow, whether through our physician. And by the way, I also know multiple patients who have gotten them not from their physician. They have found another way. One of my friends was in the ER last weekend, like just vomiting for 48 hours straight, right? Because she got it from a compounding pharmacy and it wasn't.
There's a sign. I live in New York City, and there's a pharmacy on Madison Avenue that has a sign out front that said, "We carry Ozempic, Wegovy, Mounjaro, Zepbound." It says that on the sign. Wow. So all you really have to do is walk in.
Right, right. So I think that's the other thing. It's like making sure you're getting something from your physician that, it's really can be tracked to what it's supposed to be, not just a compounding pharmacy. But that's kind of a side note.
Yeah.
But I think when people go on these drugs, like they need to think, okay, I'm going to go on this drug because I want to be healthier. I think our why always has to be health, and the weight will come off with it, but the why can't be weight.
Right.
And so that's kind of the first thing. And then the second is really like thinking about, I need to work with someone while I'm doing this. I need to work with someone. I'm getting the right dietary intervention. I need to work with a trainer to make sure I'm doing enough resistance training. So you have to think about this as a lifestyle change, similar to how you would have thought about diet before these became available. You would never just say, I'm just going to do the Mediterranean diet and cross my fingers that it works. So you can't do this with that drug either. So
exactly.
Drug, again, our plans fall really well in line with being able to kind of support a more nutrient dense capacity. That would be my opinion. Do you agree, Dr. Hanouneh?
My take on GLP-1, I mean, Kristin and I, we're not against it. I believe it's a breakthrough in medicine, quite honestly. We've been working forever on developing medicine to help with weight loss, and these efforts failed until recently. We have this very effective drug. They work, and they will kill two birds with one stone. They're very good for diabetes, and they help you lose weight and fix metabolic syndrome. But like Kristin said, I always tell my patient, make sure this drug is incorporated into a program that include diet and exercise. Otherwise, honestly, it's gonna be a setup for a failure for many reasons. One, I mean, the goal is not to stay on the drug forever. Nobody want to stay on drug forever. The goal is to take you off the drug, and we don't want the weight to bounce back, like Kristin said. If you have a diet exercise program from the get-go, will help you to maintain the weight that you lost on Ozempic or other GLP-1. And then the other factors, they do have side effect. And they, like Kristin said, I mean, I wouldn't go to online or pharmacies here and there, to get these drugs. These should be prescribed by a healthcare provider, and where technically they will start you on a small dose and titrate the dose up as tolerated, and then the other things monitored for side effect. I see it all the time: nausea and occasionally vomiting. It's a common side effect. Altered bowel habits, constipation, it's quite common. And then importantly, because of the nausea and the constipation, patients get dehydrated. So if you are on these drugs, I would say make sure you're getting enough fluids, because dehydration is quite common. And then the other factors, which is really important when you are on these drugs, is to monitor sugar. Remember, those are diabetes medication.
Right.
And you might be also taking other diabetes medication. So you put Ozempic on the top of that, your sugar may go all over the place, may go up and down and mostly down. And that's obviously is not without side effect. So I think, long story short, I'm not against them. Like you guys said, for certain individuals, they certainly help, but they should be incorporated into a robust diet and exercise program.
Yeah. And you think that after people were to go off of them, I know, Kristin, you mentioned like they are inevitably going to gain a little bit of weight back, but if they're implementing these lifestyle changes, exercise and diet, they should be a little bit better off. But isn't it true that just by nature of like that, they're no longer getting that mechanism of action, right? That's creating that low blood sugar. Right. So they're going to automatically gain, I would imagine they're going to gain weight pretty quickly when they go off of them, despite diet and exercise.
Yeah, I mean, that happened to a friend of mine. She had to go off Manjaro because she had a TIA. Is it TIA? Mm-hmm. And she's now back on it, but the minute she went off, she gained the weight, almost everything she ate. I talk about with her at least once a day. I'm like struggling with my own self, thinking like, ugh, I kind of want to try this because I've struggled with
What makes you worry? What makes you not want to try it? Because you go back and forth.
I go back and forth because I feel like they don't know what long-term effects of these drugs are. And you've said that to me.
Yeah, but I don't know. I'm not a doctor. Ask these guys.
Actually, that's a really good point. The long-term data. Yeah, thanks for bringing this up. I mean, we know, I think, from the data available that these drugs work short-term. People lose weight on them. They're good for metabolic syndrome, and data shows that they decrease the risk of cardiovascular events such as heart attack and stroke. But the long-term data is not available yet for obvious reasons. They're relatively new in the market, and that's really important. What they're going to cause long-term? Are we going to see increased risk of thyroid disease, cancer, God forbid? We don't know that for sure. So that's kind of another. My brother, he went on Ozempic and lost some weight, and actually he's been off Ozempic now for a while and able to maintain the weight, with diet and exercise on his own. He gained a little bit, but not as bad as it was before. But I would love for him not to be on the drug long term. Yeah. For the obvious reason, who knows? Hopefully, the long-term data going to be reassuring, but we don't know that for sure yet.
Well, it's funny. I mean, in my case, and I think this about me, that Jen knows this about me, is that I feel like it's a cop out, like it's an easy, like what is wrong?
It's not. But it's not. Why you say that.
I know, but you do kind of feel that way in a weird way.
You
because
feel
you're
that
like,
way because I've always done diet
done
and
all of these
things,
and I'm a yo-yo. I'm a lifelong yo-yo dieter, and so it's hard to wrap my head around the fact that, oh my God, I've done this for all these years, and now here comes something that's going to make it,
easy,
right?
Well.
Anyway.
I also have probably a handful of patients who have plateaued as well. Yeah. So they've been on them for 6 months or greater, and they'll contact me and say, hey, I've plateaued on these. I'm just like, I've lost a huge amount of weight, but I'm not losing any more. So really, one of the things I think that we really try to achieve in regenerative health is the personalization of dietary patterns based on who you are as a person, right? And I think we need more personalized medicine, more personalized nutrition. And, really, when we look at some of these drugs, it's really not personalized. So we don't know which group of patients will plateau. We don't know which one will not lose that much weight. If you look at the clinical trials, it's more effective in women than in men. Why? So do we need to change something with men? I don't know, right? But I just think as they become more available, we'll probably get a little bit more specific to that. But it's really just, I don't think it's a cop-out. I agree with what Jen was saying as well. But I think that it's really about kind of like what makes sense to me. And it was interesting, some of the conversations I had around Thanksgiving time with people saying, it's kind of sad for me that I'm just not really looking forward to Thanksgiving. At the table and all the things we did and all the cooking, and I'm just like, I want to vomit when I am now, right? So it's just interesting looking at it. It's forcing us to look at the concept of how we eat and how food fits into just every aspect, it's weaved into every aspect of our life because food is the constant, right? We can choose not to exercise. We can choose not to manage stress. You can't choose not to eat. So it's the constant that it's now our constant is being taken away.
to your point too about like Thanksgiving dinner and stuff, it's so, that's the part of it that to me is sad. It's like these people now are no longer enjoying their food.
Right.
Like you take away kind of that enjoyment and that pleasure of eating. That's something to consider as well. If you're a person who obviously you didn't get to that weight if you didn't like to eat. I mean, you obviously enjoy food, right? So you take that away and it's like, oh, that's a bummer. But I think the benefits outweigh the risks in that perspective. And personalizing it for sure, like being able to personalize, that's something that with my clients and stuff too, it's like everyone will say like, oh, how did she do it, how did she lose the weight, I want to do what she's doing. It's like, well, I don't know if that's going to work for you. Like you were saying before, the Mediterranean diet, let me just go on the Mediterranean diet and cross my fingers that it works. And it's like, well, that might not be the right thing. Maybe you need to lower your carbs. Maybe you need. So, but anyway, but thank you for giving us that lesson, because
that was good. That was an unexpected discussion.
Yeah,
I didn't think we were going to talk about that.
Little twist. We veered off. We are famous for getting off topic.
Totally. Joining us in the middle of that hyper-intensive discussion is Dr. Ibrahim Hanouneh. Tell us about it.
So he completed his internal medicine residency, gastroenterology, and hepatology fellowship training at the Cleveland Clinic, and served on the liver faculty at the Cleveland Clinic and at the Mayo Clinic. Both very impressive credentials here. He works with MNGI Digestive Health, which is one of the largest gastroenterology practices in the United States. He's presented at several national and international meetings and has been an author on over 70 papers, as well as numerous abstracts, and he is joining us now.
Yeah, so he just popped on, and we're happy to have him on to continue our discussion of the liver.
Yeah, welcome.
Thank you. I'm looking forward to the discussion. Thanks for having me.
I want to circle back a little bit. We talked earlier about this metabolic profile, metabolic typing. Can you just explain to us how the health of the liver impacts our metabolic function?
I use this analogy all the time with my patients. The liver is a security gate. Anything comes to your body has to stop, filtered by the liver before it gets in. Literally, this is how the liver functions. So you got to take really good care of the security gate. Otherwise, guess what? Bad guys going to get in. Toxins will be built up in the bloodstream. One famous toxin we test in the blood all the time called ammonia, which typically filtered by the liver. Well, when the liver is overwhelmed with the fat and other toxins, the ammonia sneak into the bloodstream, and it will build up. And once get built up, it will affect technically so many functions. One of them would be poor concentration. Difficulty memorizing things, and fatigue, generalized fatigue, and not feeling well. So that's why technically patients with fatty liver, particularly advanced degree of fatty liver disease, develop these kind of forgetfulness, and which can be mistaken, quite honestly, sometime with dementia, believe it or not. Like, there was a recent study that Kristin and I looked at the other day, where dementia have been misdiagnosed. Technically some patients were given diagnosis of dementia, and it turns out it wasn't dementia, it was liver disease. And, because they can present like that. So anyway, that's give you an idea, like, how this organ, is so important to filter the toxins from your body.
Just curious, would you say that someone who is having like memory issues and possibly looking at a dementia diagnosis, should they be looking at their liver?
Yeah, good question. I honestly, the short answer is yes. I'm not saying everybody with a dementia diagnosis has liver disease, but it's certainly like, new forgetfulness, kind of dementia-like symptoms, worth checking your liver and make sure the liver is not behind it. Probably the vast majority of dementia is unrelated to the liver, but even if there is small fraction of dementia is related to the liver, that can certainly be fixed, or reversed,
or at least to rule it out. That's, you just gave me something else to put on the list for my dad.
I was going to say, there's always a point in an interview where it turns into a personal doctor's appointment for Jen.
For me. No, but these, I never knew that. I never knew that. That's fascinating to me. So, okay, so with metabolic typing, then I just want to talk about diet for a second. What kind of a role does metabolic typing play in someone's dietary needs?
Yeah, so for the 4 different profiles that we reviewed, really it's going to boil down to what should be your carb content. If you are unlean and you are not healthy, then you're probably going to benefit a lot from being on the lower carb end. Now, we don't recommend keto because we have found in both our patient bases that keto does not tend to be very sustainable for the majority of individuals. Most people can maintain it for about a 1 to 3 month period, and then they go back to their old habits because it's really hard to maintain. There's great benefit if you can maintain it, really, but the maintenance of it long term. So we're always thinking about what can our patient do today, 5 months from now, 5 years from now? Right. And that's really going to be kind of the sweet spot of how they look at their diet. But if you're someone who's really metabolically challenged, all your numbers are off, your waist circumference is up, there's really a tremendous amount of evidence looking at the concept of low carb, which is about 25% of your calories coming from carbohydrate, as a really great solution with being able to kind of reverse some of these metabolic abnormalities. Now, I think it's also important to say that you can do low carb in a very healthy manner, which is how we've communicated it within the book. I have patients that say, well, I'm going to go low carb and I can't wait because I can have steak every night, right? Because as long as I don't have any carbs, right, we're good. That's not really the case. What we did is we really looked at the Mediterranean diet, which still prevails to be the most beneficial diet in terms of overall liver health. And then we altered carb content based on whatever the profile was. Okay. So really the base is the Mediterranean approach, but then the carb content comes down based on where you are metabolically speaking.
Okay.
How does intermittent fasting factor into what you would tell? Because we've had some people who say that you should do it as a woman. I'm told it's not so good, but maybe I'm a postmenopausal woman, so it can be good. There's a lot of mixed messages, I think, when it comes to that.
Yeah, we do talk a lot about intermittent fasting and the different types within the book. I think intermittent fasting can be really beneficial. And I'll tell you one place, and Dr. Hanouneh can share his patient stories, but the place that I see it really helpful is I have a huge chunk of women, probably 70% of my practice, and they all tell me one line: I'm perfect throughout the day. And then at 8 o'clock, everything goes to hell, right? So intermittent fasting has been really useful for that patient base where they are actually on a schedule, a frequency. They're on a feeding schedule and on a fasting schedule. And so if you're scheduling it, let's say you're eating from 10 to 7, well, things can't go to hell at 8 o'clock then.
Right.
Because you are in your fasting state after 7 o'clock. Right. So for a lot of my patients, it really has been useful there. There, of course, are studies looking at blood sugar management and intermittent fasting. I think, Lori, it really depends on the type of intermittent fasting. And there's probably 5 or 6 types that are very popular. So the type is dependent on your chronic disease risk. Are you pregnant? Are you breastfeeding? Are you over the age of 70? All of those things have to get factored in, but changing our frequency is really beneficial because at the end of the day, we're not meant to eat all day. I mean, we are not meant to be eating around the clock.
Yeah.
And that's something too, just to say in the past, I think people were told, and we've talked about fad diets and different things here. And we were told, well, make sure you eat every 4 hours, every 2 to 4 hours, and have a snack and have, then it's like
small meals.
Well, no, you're constantly taxing your body that way. Right. So with the intermittent fasting, you're saying it would depend on what the person's sort of, background is, their biology or whatever what it is that they need to do would depend on what type of an eating window you would suggest for them.
Yeah. Biology, I think scheduling, some of the people that are high level CEOs that I've worked with, they can't do time restricted eating because they have dinner meeters, but they can do a 5-2 method where they only fast 2 days out of the week. Right. So I think that's dependent. I'm sure, Dr. Hanouneh, I'm sure you've seen patients that are, type 2 diabetics that you probably don't recommend fasting at all because of blood sugar fluctuations. So I think speaking to your doctor at the end of it is really the most important factor.
Yeah, for sure. No, I would say, yeah, intermittent fasting, I mean, it's not for everyone, that's for sure. At the very, very late stages of liver disease, where you're almost at the edge of liver transplant, we recommend actually against it. But that's like a small fraction of patients with liver disease. Kristen's points, it's well taken. Patient with type 2 diabetes, they need to pay attention to their sugar and consult with their doctor. But outside that, I mean, it's fabulous. It's definitely give time for your body to burn the fat in your liver. In my experience, I start slow and go slow with my
Okay.
patient.
Yeah.
So I'll tell them, okay, well, let's do 4 or 5 hours a day, for a day for a week or two
Yeah.
weeks, and then let's go up a little bit the next day. Ideally, if your time work allows, would be at night time. Like, would be, let's stop snacking after like 7, 8 p.m. And not have anything until the next day, 8 a.m. in the morning. So that's 12-hour intermittent fasting. So yeah, I start slow, go slow, and then and build up from there. And I'll tell them, you don't have to do it every day, 3 days a week, maybe to start with. And you don't have to do it over the weekend. Reward yourself over the weekend for doing intermittent fasting the 5 days of the week. Those kind of things, I found them helpful, like, to achieve good outcome.
Okay.
Yeah, I have a friend who fasts he doesn't eat anything every like third day or every fourth day, I guess.
I want to go back for a second about this liver dysfunction. And are there signs and symptoms that people have? I know we talked a little bit about like diagnosing it in the different testing, but is there something that like somebody would feel as a symptom of liver disease?
Oh, that's a really good question. The short answer, believe it or not, is no, particularly
Oh.
early on during the disease. Fatty liver disease, I call it silent disease, meaning it really doesn't give you symptoms, or may give you non-specific symptoms like fatigue, which is obviously very non-specific. Sometimes a little bit of pain in the right side of the abdomen, intermittent every now and then. Like we said, poor concentration, etc. Very non-specific symptoms, or may not give you symptoms at all. You feel just fine.
Wow.
And that's really, really important, because here's gets the screening. Meaning, if you do have risk factors for fatty liver disease, you got to look for it. Otherwise, you may not have symptoms until it's too late, where, God forbid, you have cirrhosis or liver cancer. Obviously, at that point, you're going to have symptoms, but you don't want to wait that long. So that's why the American Association for the American Diabetes Association came out recently with guidelines. They said if you do have type 2 diabetes, you need to screen for fatty liver. You need to check for fatty liver, even if you don't have any signs or symptoms of liver disease. If you have metabolic syndrome like sleep apnea, high blood pressure, high cholesterol, obesity, family history of fatty liver disease, you got to tell your doctor during annual physical, is like, well, let's check my liver. Do I have fatty liver? And screening, quite honestly, is pretty easy. It can be done by two things, plain and simple. One, blood test to check your liver, and number two, ultrasound picture of the liver to see if there is fat there. Typically, we start with a blood test, and if the blood test abnormal, maybe that will trigger doing ultrasound or picture of the liver. But yeah, no, good question. It's a silent. I don't want to sound. It's a silent epidemic. It's very, very common disease, and we call it silent epidemic for that reason.
Yeah, totally.
Okay. And is the checking liver enzymes, is that just part of a regular metabolic panel, or is that something you have to ask for specifically?
It's a routine test. It's called liver function test. So yeah, routine. It comes. It depends where you go for the blood test, but sometimes comes under liver function test. Sometimes comes under complete metabolic panel.
Got it. Right. I see them.
A lot of physicians during annual physical, a primary care physician or family doctors do it. Yeah, a lot of them do it now as part of routine blood test.
Okay. Is it possible to change your metabolic profile and change your metabolism as you? I mean, it changes. Or is it true that it changes as you age?
It doesn't stay the same, and would love to hear Kristen's feedback on this. It doesn't stay the same, and yes, the short answer, you can change it. you can change it because of your liver, because of the power of your liver, believe it or not.
Wow.
The liver has a capacity to regenerate, you know, which is honestly, it's what fascinates me about the liver the most is this regeneration. That's where the name of the book came from, Regenerative Health.
Yeah.
So I'll give you a little anecdote and then I'll go back to your question. We do live donor liver transplant. When someone
Wow.
with liver disease need transplant, you take a piece of a liver from a loved one and you give it to a patient who need liver transplant. If you scan the donor and the recipient, just few weeks after the surgery, the liver is back to the original size.
Wow.
It's almost like a
incredible.
science fiction.
Yeah.
And there is no internal organ that does this except the liver. It's the only organ that has capacity to regenerate. So on
Wow.
that note, if you like fix fatty liver, yeah, your liver regenerates, your metabolic profile changes, and you remember those 4 metabolic panel file we mentioned in the book. You can technically jump in between those types. You're not going to be in one type forever. The goal actually is to have you go to a better type with the changing diet and those things.
I just want to talk quickly about detoxing the liver. I mean, what are your thoughts on, because people ask me this all the time. It's like, well, if I take milk thistle tea and I do apple cider vinegar, and what are your thoughts on those types of things to detox the liver? Is there such a thing?
Too. I get people that will come to me and say, hey, I'm going to do a liver detox. And, can you check out this brand? Is this a good brand? Or I'm just going to have celery juice for a week. So I always say, you know what, you would be much better by taking the money that you spent for that liver detox and going out to get some fruits and vegetables.
Right.
So we don't have the science supporting some of these detoxes. Some of them can be downright dangerous. They can cause electrolyte imbalance, etc. And I think that's where kind of like we use the word, I can't remember what you said, Lori. It was like, you're taking a shortcut or you're taking the easy way out.
Okay. Yeah, it's a cop out. Yeah.
It's a weight loss when we were talking about Ozempic, some of these drugs. And when you think about the liver, there's no shortcut. There's no, well, gosh, I'm drinking too much and my diet sucks. So I'm going to do this liver detox once a month and that's all going to negate everything that I'm doing, all the damage. We don't have any evidence that these things do anything but potential harm, both to the liver and overall to the microbiome. So I think we need to kind of shift the focus and we need to look at food as medicine, not a product as medicine. So I don't think these things work. I know Dr. Hanouneh has good data on the ineffectiveness of milk thistle, even though it's very popular. So I think, at the end of the day, it boils down to really looking at places, what people have done in places where longevity is just, vibrant. So looking at the blue zones,
sure.
At places like this, no one in the blue zones is doing a colonic. No one is like taking a liver cleanse once a month. None of them are, and yet they're living longer than all of us with less ability. So to look at that as something that, regardless of the marketing, the smoke and mirrors, like what works in people that have lived longer.
Yeah. I mean, I'll tell you the best detox of the liver. You're not going to believe it. Coffee, black coffee.
I love that.
Studies have shown over and over and over that the best medicine, if you will, or detox of your liver is coffee. Indeed, it counteracts the impact of alcohol on the liver. 1 or 2 cups a day, black coffee. Ideally, don't mix it if you can with other things. That's probably the best medicine and detox of the liver. Unfortunately, other things don't work. I wish they do. I really do. I mean, they study milk thistle over and over, and the results, consistently have been negative.
Yeah.
It doesn't harm the liver. I don't think it does anything bad for the liver. It's just like Kristin said, you're wasting your money. I mean, no, there are several studies from Europe, from here, showing that coffee has been very beneficial to the liver.
Right.
And what is it about? Is it the caffeine in the coffee, or is it some other compound in the coffee?
Good question. We think both.
Okay.
A study of decaf has not been as good, has not been
Okay.
as powerful. So it seems like it's decaffeinated coffee that does the job. But it's not just the caffeine. It seems like, other compounds in the coffee that does it. It's actually a hot area for research. A lot of pharmaceutical company invested into this because it would be nice to find what's in the coffee, put it in a pill for those who don't like coffee, and come up with a liver medicine.
Of course.
Yeah.
And who drinks decaf anyway?
I know.
What's the point? What's the point? It's like, that's a waste of time for me. But I always drink black coffee, so that's good. Maybe I've just been detoxing my liver
I put
all
some
this
almond
time.
milk and things in there for sure.
I just want to talk a little bit about some of these clinical trials and the new research. And is there anything that's coming down the pike in the field of hepatology that you're excited about, or anything that's new and exciting?
Well, in terms of fatty liver, there are a lot of medicine currently in the pipeline, research pipeline, to fix fatty liver. We do expect, some of these medicine be approved by the FDA, sometime this year and maybe next year. One of them, going back to GLP-1, believe it or not, has been studied for fatty liver, and the preliminary data is very encouraging. So we do expect GLP-1 to be approved to treat fatty liver in the near future.
Okay.
And then there is another medicine, what's called remistrone. It's not approved by the FDA yet, but probably will be approved soon. It seems to stimulate a thyroid receptor. So I'll give you a little quick background.
Yeah.
There are
Sure.
two thyroid receptors in the body. One of them obviously in the thyroid, and the other one, believe it or not, is in the liver. And this medicine, it's a selective stimulator of the thyroid receptor in the liver. So almost like, turn the liver into hyperthyroid state, burn the fat really quickly. The result was released in the New England Journal of Medicine just a few days ago, and it's positive. It seems to be helpful. The problem with that medicine, it doesn't fix metabolic syndrome as a whole, which would be nice to have a medicine that killed two birds, one stone, treat diabetes, treat metabolic syndrome and fatty liver, rather than just focus on fatty liver. But it's certainly a step in the right direction.
That's great. That's so interesting.
I
thank you so much for spending all this time with us.
I want to say the name of the book again. It's Regenerative Health, Discover Your Metabolic Type and Renew Your Liver for Life. Kristin, there it is.
There it is.
Thank you, Kristin Kirkpatrick and Dr. Ibrahim Hanouneh for being here. It really was a great discussion. Thank you so much.
Thank you very much for having us.
Thank you.
All right, wowza. That was so
Did you know any of that stuff?
No, no one talks about the liver. No. You only hear about the liver when you're talking about alcoholism, or something, or when something goes horribly wrong with the liver. Yeah. That's when you hear about it. Not just like every day. How you should think like, oh, my waist is
from a metabolic standpoint, it's like,
oh my god,
wow, I didn't know. Yeah, that was great. And I'm so glad that Dr. Hanouneh jumped
on.
I know,
he jumped on in the middle. Like at first we thought we weren't going to have him, but he added that kind of medical perspective that, but wow. And yeah, maybe this will convince me to go on.
We talked a lot
about
more about that.
Me too. I didn't think that we were going to talk about that, but I guess it has to do with that.
Sure. Yeah. I mean, they're seeing great results with patients who are lowering their risk. So I love that conversation. That was great.
That was a good discussion. We hope you liked it too. I'm Lori Schulweiss.
And I'm Jen Giamo.
And this was Everybody Talks.
Talk to you next time.
Take care.
For more information about our podcast, to learn more about us, and to catch up on all of our episodes, go to our website at everybodytalkspodcast.com.
Follow us on Instagram at Shuli, at Jen Giamo, and at Everybody Talks. And if you want to watch today's episode, go to our YouTube channel at Everybody Talks Podcast.
Join the Everybody Talks community by checking out our Facebook page where you can ask questions, post comments, and be part of the conversation.
And don't forget, if you like what you've heard, give us a 5-star rating, write a review, and tell a friend. We're for everybody and everybody. The Everybody Talks podcast is co-created, executive produced, and hosted by us, Lori Schulweis and Jen Giamo. Produced and edited by Eric Jackowitz.
Our theme song music is written and performed by Jackie Ryle and Aaron Navisi, with additional support from our pups, Oliver, Milo, and Murray.
Talk to you next time.